A right hand dominant patient arrives in your clinic. He reports that he had an injury when his finger was hyperextended. He felt a snap which occurred and experienced immediate pain in the ring finger. He reported no previous injury history. The patient complained of pain at the level of distant phalangeal joint of the ring finger. The patient has further swelling and tenderness and could not actively flex his finger at the level of DIP joint. Upon making fist, there is a noticeable lack of flexion compared to the other digits. The flexor digitorum profundus of the other digits were intact and demonstrated by blocking the digits in extension at the level of middle phalanx and asking him to flex at the level of DIP joint. The FDS was intact in all fingers and demonstrated by blocking the adjacent digits in extension at the level of proximal interphalangeal joint and DIP joint and asking the patient to actively flex at the level of PIP joint of the examined finger. Active extension was possible at the metacarpophalangeal joint and DIP levels of all other fingers. He has no complaints of numbness or tingling. He has no complaint of pain at the palm, wrist, or the forearm. A differential diagnosis here can be a bony flexor digitorum profundus avulsion, fracture dislocation of the distal phalanx. An X-ray was done which shows a small bony avulsion is seen at the volar proximal aspect of the distal phalanx of the affected finger. The diagnosis with bony flexor digitorum profundus avulsion. This is the classic history and presentation of acute Jersey finger. 4 types of FDP avulsions are described by Leddy original classification. Type 1. Distal tendinous avulsion with proximal retraction into the palm. Type 2. Distal tendinous avulsion with retraction at the level of PIP joint level. Type 3. Distal bony avulsion with retraction to the A4 pulley. Type 4. Distal bony avulsion with FDP avulse from the Brony fragment. This case is an example of type 3 or type 4 injury diagnosed by radiograph and clinical examination. Surgical exploration differentiate types 3 and type 4. The ring finger is the most common profundus tendon avulsion. The typical presentation is in sports injuries when the patient grabs the opponent jersey in a tackle, undergoing forced extension of the fingertip while the profundus is under maximal contraction. Thus the name jersey or rugby finger was coined. Type 1 and 2 injuries are defined as FDP retraction into the palm and finger respectively with subsequent rupture of the short and possible long vinculi. The patient with a type 1 injury often had swelling in the pain and tenderness in the palm, and patient with type 2 injuries has swelling, pain, tenderness, and decreased motion at the level of a PIP joint. Sometimes a small fleck of bone is seen volarly at the level of PIP joint in type 2 injuries. A comfortable ulnar gutter splint was applied to the patient with the ring and small finger in an intrinsic plus position. He was scheduled urgently for operative intervention surgery. Type 1 injury should be repaired within 7 to 10 days as the blood supply is theoretically compromised due to rupture of long and short vinculae when the long tendon retracts into the palm. 2, 3, and 4 injuries have a longer safety zone for repair, with successful reports greater than 2 months after the injury. Other repair is recommended to facilitate rehabilitation, decrease morbidity, and prevent a possible conversion to a type 1 injury with the later rupture of the long vincula and retraction into the palm. The patient is shifted to the operation theatre in an operating room after obtaining general endotracheal anesthesia. Regional block is also an acceptable alternative. The arm was placed in the hand table with well-padded proximal arm tourniquet. After prep and wrap, the limb was accentuated with the Ishmael bandage and tourniquet inflated to 250 mmHg. A Wohler zigzag incision was made at the level of DIP joint of the ring finger, and exploration under the loop magnification was performed down to the flexor sheath. Hemostasis securing using bipolar cautery and both neurovascular bundles were carefully protected through the procedure. The sheath was opened distal to the A4 pulley, taking care to preserve this pulley throughout the procedure to prevent bowstringing of the tendons. A window between C3 and a A5 pulley was opened to expose the distal bony avulse fragment, and it was seen that the FDP tendon was still attached to this piece of distal phalanx, indicating it is type 3 injury. Hematoma and debris was curettaged after the piece of avulse site. The piece was reduced and held in position with 0.035 inch K wire and under fluoroscopy 1.5 mm titanium self-tapping screws were placed in a bicortical purchase. The fragment was seen to be stable in the range of motion. Tourniquet was deflated, hemostasis secured, the skin closed with 40 nylon sutures with a bulky dressing being applied, and then after a dorsal blocking splint applied with the wrist in 30-degree of flexion. The finger was splinted in intrinsic plus position to relax the FDP and prevent postoperative stiffness. 1 and 2 type injuries necessitate exploration at the level of PIP joint, where an additional palmar zigzag incision is used to explore the flexor sheath. A transverse incision is made at the sheath just distal to the A2 pulley or through the C1 pulley. If the FDP tendon is not found in this level, then the additional incision is made in the palm and the flexor sheath is opened proximal to the A1 pulley. If the tendon is found at this level, it is classified type 1 injury, and long and short ventricular rupture in the blood supply is theoretically compromised. The tendon is retracted proximal to the flexor sheath, preventing this source of nutrition via intrasynovial diffusion. This necessitates early repair within 7 to 10 days to prevent necrosis and myostatic contracture that may develop. A 4-fluorine suture is placed as a core suture in the proximal tendon stub. An infant feeding gastrostomy or a Swanson suture passer is placed in retrograde fashion from just distal to the A2 pulley at the PIP joint through the flexor sheath. Care is taken to place the tubes passer through the FDS desiccation and exit proximal to the A1 pulley. The tube suture passer is attached to the core sutures and the tendon is pulled distally at the level of PIP joint. Next, the tube passer is fed retrograde under the A4 pulley from the DIP level incision, and a tendon is pulled distally to the avulsed area of the distal phalanx. Care is taken to preserve A2 and A4 pulley to prevent bowstringing. A 25 gauge needle can be used to spare the tendon at A4 pulley to secure its position. A bone trough is created at the proximal Wohler aspect of distal phalanx. 2 heavy needles are drilled through the bony trough Wohlerly, exiting dorsally and distally through the nail plate. The core sutures end are pulled through the eye of the needle and pulled through the distal phalanx and the nail. They are pulled, snugged and tied securely over a button, and the remaining stump of tendon at the base of the distal phalanx is sutured over this repair for additional security. The sheath can be left open or repaired, depending on the surgeon's philosophy. The closure and the postoperative care is similar in type 3 injuries as before. The sutures and buttons are removed at 6 weeks after the surgery. If tendon was initially found at the level of PIP joint, upon exploration, it is classified as type 2 injury. The long vancula in type 2 injury is assumed to be intact, providing some nutrition and preventing further retraction of the tendon into the palm. The short vancula from the distal end of the middle phalanx is ruptured. The tendon still lie in the flexor sheath and retain nutrition by transsynovial diffusion. Due to these fractures, the repair has been reported for more than 2 months delay even. If upon surgical exploration a type 4 injury is found, then reduction and fixation of bony fragment would be performed with screws as described before. The avulse tendon from the bony fragment would then need to be repaired at the distal phalanx separately as described at type 1 or type 2. Postoperatively, the patient will be seen following a week and starting with flexor tendon zone 1 passive range of motion protocol. Dorsal blocking splint is applied, keeping the wrist in 30 degree of flexion, MZP in 6 degree of flexion. A second dorsal blocking splint was applied at the digit to maintain 45 degree of flexion at the DIP joint. Passive flexion of the digit was allowed out of the splint several times a day. A modified passive hook fist and passive PIP extension was allowed at the with the ME joint being flexed. Place and hold were performed for the FDS. Wrist extension to 10 degree was allowed with a finger flexed under therapist supervision. Sutures are removed at day 10 and radiograph obtained to ensure that adequate reduction of the fragment and progression through the healing. At 21 days post-op, active range of motion is instituted with a full fist, place and hold, and digital blocking splint was discontinued. 20-day post-operatively started with tenodesis exercises of the wrist, gentle isolated FDS exercises, and finger hook fisting. At 35 days, full DIP motion is allowed, including extension. A union of the fracture is achieved in 12 weeks' time.